is going to be on myocardial. Sorry, our session is going to be on myocardial infarction. Kisato, welcome to the forum. This is the KNH-UoN forum. We have today our speaker, Nangaleki Kisato, sorry. She's one of our nurses who's specialized in cardiac nursing. I thought it was important for us to have the perspective from cardiac nursing on cardiac related issues. And Kisato, how are you?
I'm fine.
Yeah. So you can share your slide, and Nelson will give you leeway for you to share your slide, and you can teach us what we do wrong or what we do right, and what you see on the in KNH on cardiac related issues. Over to you.
Okay. Just give me a minute. Listen, now, how do I go about this? This thing. So while I am trying to find out how I'm going to do the post it on the presentation, I need assistance. How do I?
You can share your content. That place for share your content, and press the. Yeah, or you can just send it to me. Or Nelson. We can do the sharing.
Nelson has
okay, so Nelson, if you have it kindly, yeah, thank you. I can see he's projecting it for you.
Okay.
Nelson, kindly share the screen. It's okay. He's going to do that.
Okay.
So as usual, for the audience, kindly put your questions on the Q&A. For the chats, we'll just be having general conversations. But if you have any questions that you would like to be addressed, kindly put it on the Q&A. Thank you.
Okay, so thank you for this opportunity. As you have heard, I am Nangaleki Kisato. Cardiac nurse, critical care nurse, and I have an interest in cardiac nursing. Welcome to this webinar today. And I'm going to be talking about myocardial infarction. And I would like to concentrate more on Kenyatta and how we go about helping our patients. So the next slide. So as we know, we have quite a number of non-communicable diseases, diabetic, hypertension, and these are under cardiovascular diseases. And we have noted that 50% of these non-communicable diseases are accounting for our hospital admissions, and 55 of them are hospital deaths in Kenya. Cardiovascular diseases are responsible for much of the burden that we have, and this is a survey that was done in 2018 in Kenya. Next slide, please. So it has been noted that the cardiovascular diseases are one of the causes of death globally. So when we look at the global end of the spectrum, we have noted that it estimates that 17.7 million people die of these CVDs each year. And this representing of 31% of all global deaths. Of these deaths are estimated that 7.4 million are due to coronary heart disease. And this is where we're going to be concentrating on. While the 6.7 million are due to stroke. Over 75% of the CVD's death take place in low and middle income countries, mostly affecting the poorest people. As we know, we are in the third world country. Next slide. Now I go to the household level. There sufficient evidence was emerging to prove that the cardiovascular diseases and other non-communicable diseases contribute to poverty due to catastrophic health spending and high out-of-pocket expenditure. And that at macroeconomic level, the cardiovascular diseases place a heavy burden in our economy, both of low and middle income countries. Most of these diseases can be prevented by addressing the behavioral risk factors such as unhealthy diet, obesity, physical inactivity, harmful of alcohol and tobacco use. Next slide. So as you have seen in our lifestyle, this is I want to pose a question. In your current situation, in your own situation, when it comes to your homestead, do you think that you have one of these criteria that will lead you to have a cardiovascular incident? Either you're obese or you are leading to obesity due to a sedentary life. You are either doing some habits of either you're smoking. Let's remove the genetic factors. These are environmental issues that we can actually control so that we don't lead ourselves into having the burden, which is already constraining us, especially in Kenya and let's say in Kenyatta itself. Now, let's go to the definition of the myocardium infarction. So what is myocardium infarction? This is whereby there is necrosis of the myocardium. As we know, the myocardium is the muscle in the heart, and this is caused by occlusion of the coronary arteries. Coronary arteries are the blood vessels that supply oxygen and nutrients to the heart muscle, that is the myocardium. Once if there is an occlusion, then the area that is supposed to be supplied by the nutrients becomes ischemic, then necrosed. Hence, its function is reduced or stopped. In the extreme consequences of acute coronary syndrome, the spectrum of clinical status caused by the instability of the coronary artery lumen due to a plaque instability and the thrombosis or atherothrombosis. Second, next. Next slide, please. So either one of the following criteria will satisfy the diagnosis of an acute, evolving, or a recent MI. So number one, typical rise and gradual fall of troponin or more, may cause the rapid of the, have we jumped a slide? Okay, yes, we are on point, sorry. There's a typical rise and gradual fall of the troponin. Troponin is an enzyme that we do a test on the blood, and it usually coincides with a finding of the ECG, that the electrocardiogram that you usually do to confirm the presence of an MI. Also, CKMB is usually a test also we usually correlate with the two to see if the patient is having a myocardial issue. The ischemic symptoms are we have ischemic symptoms. There's development of pathological Q waves on the electrocardiogram. There's electrocardiographic changes indicative of ischemia. The artery, the coronary artery intervention that we do in Kenyatta, which usually also confirms the electrical and the blood that we have tested. Then you have pathological findings of an acute myocardial infarction. Next slide. Next slide, please. Thank you. So, pathophysiological principles. So most patients who sustain MI have a coronary atherosclerosis. That means there's either fat deposits in the coronary arteries leading to ischemic processes in the area that is supplied by the blood, hence you get an MI. The thrombus formation occurs mostly often at the site of the atherocyte, where there is the lesion. This obstructs the flow to the myocardium tissue. When you don't have oxygen and blood supply and the nutrients that the muscle needs to to make it to work, then you end up having the necrosis. This process then leads to either the rupture of the plaque, which is believed to be triggered mechanism for the development of the thrombus, hence most patients with an MI. When the plaque ruptures, the thrombus is formed, and at the site that could occlude the blood flow, hence patient happens to have an MI. Next slide, please. Next slide. Thank you. So the irreversible damage to the myocardium can begin as early as 20 minutes to 40 minutes after interruption of blood flow. The dynamic process of infarction may not be completed, however, for several hours. Necrosis of the tissue appears to occur in a sequential fashion. The cellular death occurs first in the endocardial layer and spreads in a wave front through the thickness of the wall of the heart. The shorter the time between coronary occlusion and coronary perfusion, the greater the amount of myocardial tissue that can be salvaged. Between the necrosis, we try not to have the patient go to necrosis. When the patient has the first insult, we prefer having the first angiogram, the first reperfusion of the coronary when the patient is having the ischemic part. When it comes to necrosis, it means the area is dead. Even if we do the reperfusion, it will not be that much beneficial to the patient as it were if you had gotten it during the ischemic process. Now, this is it's a picture. It illustrates how the plaque is formed, how it occludes the blood vessel, and how you end up lacking oxygen on the blood flow. Hence, on the heart, where it shows that it has been occluded, then the flow is not, the area is not getting enough oxygen. What happens to the cell? It dies. But before the cell dies, there is always ischemia before you get to necrotic part. Thank you. Next slide. Thank you. Pathophysiological principles still continues. The cellular changes associated with the MI can be as follows. There's a development of infarction, that is new myocardial necrosis. There's the infarction expansion. This is when the thinning and the dilation of the infarction zone. Then there's ventricular remodeling, that is the thinning and dilatation of the ventricles. As we say, most of the MI usually affects the ventricular part, and usually try not to have the left ventricle, which is the pumping system of the heart, being affected. MI most often results in damage of the left ventricle, and this will lead to the left ventricle reducing its function. Infarction can also occur in the right ventricle or on both ventricles, but most of the time, we usually tend to have patients more having the left ventricle because the left ventricle needs more. It's the pumping system, so it needs more energy. So you can imagine an artery, the left arterial descending artery is occluded. What happens? Necrosis of the entire part, ischemic, then necrosis of the entire part. Now let's go to MI classifications. It is usually classified according to anatomy of the place that has happened. So usually have the transmural and the endocardial. When it comes to diagnosis, usually have two. We have the STEMI and the non-STEMI. This is the ST elevation myocardial infarction, and this ST is usually found in a graph whereby we are able to know the ST has gone up, and that is usually the active phase of the MI. We are saying that point is ischemic. If you get to the cath lab at that time, we're able to reperfuse that area that has lacked oxygen and nutrients. When it comes to non-ST elevation, that means the effect has already happened and you have moved, whereby the patient has a necrotic area. Now the ST has already gone down. So at that time there is no elevation, but it's usually an indicator. When I do an ECG and see an ST depression and ST elevation, MI, I usually check on the QS and the ST depression. It usually indicates either you had a prior MI insult that was either not sorted or it was sorted, but you still have an indication of. MI can be, next slide, please. So MI can be located in the anterior side, septal, lateral, posterior, and inferior walls of the left ventricle. If you have noted, most of the MI conversation will concentrate more on the left ventricle. As I said before, the left ventricle is the main pump of the heart. The right side usually doesn't do much because it usually receives more of the heart and pumps out more, or it receives, so it doesn't have much of the pumping effect. So as you can see illustrated by the picture, the types of the supply, the blood supply supplied by the arteries in the heart, in the different parts of the heart. As you can see, the left circumflex artery, which usually comes from the left anterior descending artery. You have the right coronary artery, usually supplying the part of the right artery. But if you compare, the left coronary artery supplies more of the left side. So this is where we try not to have any blockage, hence not affecting our left ventricle function. Next slide. This is also a diagram of the coronary artery arising from the aorta and encircling the heart. So some of the coronary veins are also shown. So if you can see, there's the left main coronary artery that is on the left side usually divides to two. That is the circumflex and the left anterior descending. When you go to the right, you usually have the right coronary artery and the posterior descending artery. Both, if you see, if you are able to see way down to the ventricle, they always meet somewhere down there. But you see, most of the supply usually comes from the left side of the heart. Thank you. The next slide. I'm sorry, it's a bit blurry. I will try to it shows mostly the anatomical location, the coronary artery that supplies that anatomical location. If you do an ECG, what do you see on the ECG and the clinical implication of that insult? So if you might take the lateral wall, the lateral wall is usually supplied by the left circumflex, and they supplies blood to the left lateral and the left posterior walls of the sinoatrial node is 45%. The AV node is 10%. So if you get an insult on the lateral wall, then you either get an insult on the SN node, meaning that your heart rate will be affected, and the two pacemakers, the sinoatrial node and the AV node, will be affected. This, when you do an ECG, you'll see changes from the normal ECG in lead 1, in AV lead, in lead 6, lead 5 and lead 6, and you see a Q wave and ST segment elevation on those leads. This means that the evaluation for posterior wall involvement, some hemodynamic changes, dysarrhythmia, which is caused by the SA and the AV node dysfunctions. So I've just picked one. We can go, it's been recorded, so you're able to get the notes, and you'll see the different areas of the heart and their supply, and what changes you get in the ECG, and what clinical features will present with each. Next. Now, what are these common heart attacks? Because when a patient comes to our unit or the casualty, what are these common heart attack symptoms that may necessitate a nurse, a practitioner, to be able to either think, let's do an ECG and see. So they're mostly described, patients usually describe as having a chest pain. This symptom can be mild and feels like or severe, like a crushing pain. It may start in the chest or relate to other areas of the left arm or both arm, shoulder, and towards the waist. Patient comes with shortness of breath or troubling breath. Some may come with nausea and stomach discomfort. Some may come with palpitation, some impending doom, sweating, and feeling lightheadedness. This is not it's not pest to a point whereby you have to have all these clinical signs for you to say this patient has an MI. It can come in different forms. Shortness of breath can also indicate other things. But before you think that, check history. That's why we say history matters, so that it helps you in making the right diagnosis and the right treatment for this patient. Just in case, let me give you a scenario while we are continuing, and I want you to think of this. 28-year-old male, Asian, non-asthmatic, have been being followed up at the chest clinic because of the asthma. Presents with an asthma attack, same at the clinic because it's a follow-up clinic, was nebulized, still no relief, same sent to the accident and emergency area to be sorted out, still has symptoms because there's no relief, was admitted in the same hospital in the ward, still having the same symptoms. Now, if you place this patient as shortness of breath and troubling breath, then it should necessitate you to do an ECG on this patient. But then, in our mind, we usually say MI usually has this, you're either diabetic, hypertension, then you'll be thinking of doing an ECG. This is a 23-year-old male, no history, apart from he's Caucasian, he's Asian, and he has asthma history. Please, food for thought. We'll talk about, I'll give you the diagnosis later. Next slide. Now, in women, as we are saying, we women are unique to men. Our symptoms are quite different. A man will come crying and say crashing. Some of us will just say, I just had an epigastric pain. Both should not be treated differently if there is suggestion of an MI. Then the medical research in recent years has shown that women have the above symptoms, but also have a higher chance of experiencing symptoms different from those listed above. We are likely to describe the following. We say chest pain, especially in the chest, center of the chest. We can feel indigestion. We are more likely to describe shortness of breath, fatigue, or have not slept. That is also a sign. Pain in the back, shoulders, neck, arms, abdomen, and then nausea and vomiting. Anyway, as we are all medics, when we come with such symptoms, I know a PT test will be done first, but then, as we say, history. It won't take you more than 10 minutes to do, more than 5 minutes, or even less to do an ECG. Even if you don't need to print, just do an ECG. You might get enough information to help these patients. And we have lost quite a number of patients because of such symptoms that do not correlate with the standard symptom set for an MI. Now, let's do an assessment on this patient. Patient who comes with an MI describe a heaviness, squeezing, choking, or smothering sensation. Note, it is not pest on stone that they have to come with this. Patient often describe the sensation as someone is sitting on their chest. As you have seen, female have a different way of saying they have a chest pain. The substernal pain can radiate to the neck, left arm, back, or jaw. Unlike the pain of an angina, the pain of an MI is often more prolonged and unrelievable by the rest or sublingual NTG. As you've noted, there's an angina and there's a full-blown MI. So people start with an angina, I feel numbness, it goes. When you change position, it's either postural, you change position, or you take deep breaths, then it settles. But when you progress to an MI, it's a more prolonged pain. Even if I give you an NTG, it might not relieve it. Hence, you're active. When you come to an angina, when I give you an NTG and it relieves, then that's an angina. But it should not negate that the patient might progress to a full-blown MI. Associated findings in history include they have a nausea and vomiting, especially for the patient with inferior wall MI. I will take you back to that graph showing the different parts of the heart that are usually affected, what ECG findings you see, and the signs and symptoms that you might find this patient presenting with. Those with GI complaints are believed to be more severity are believed to be related to the severity of the I'm not able to see down there to go related to the severity of the pain and resulting into a vagal stimulation. Next slide. Patient with MI describe a heaviness. Next slide, please. Next slide, please. Thank you. So we continue with the physical examination. The patient usually appear restless and in distress. They usually come in a warm and moist in their skin. They're usually probably cold and clammy at that point in time. Breathing may be labored and rapid. You might find fine crackles, because crackles or rhonchi may be heard when auscultating the lungs. There's increased blood pressure because they're anxious, they're in pain, and the feeling of doom. The heart may vary from a brady to a tachy. Note the brady and the tachy in relation to where the blood supply was cut by the thrombus. I'll refer you to that chart. On auscultation, the first heart sound may be diminished as a result of decreased contractility. A fourth heart sound is heard in almost all the patients with MI, whereas a third heart sound is detected in only 10% to 20% of the patients. You might have transient systolic murmurs. After 48 to 72 hours, many patients acquire a pericardial friction rub. Patients with right ventricular infarcts may present with jugular vein distension, peripheral edema, and an elevated central venous pressure. Next slide. Next slide, please. So this is an ECG. I'm sorry I wasn't able to put how a normal ECG looks like, but we'll kindly go back to the anatomy and physiology. We'll be able to see how a normal ECG looks like so that you may be able to appreciate the kind of ECG I've presented right now. The ECG detect pattern of ischemia, injury, and infarct. So if I may just pose a question and allow just one person to just mention two things that are seen that you might think that are abnormal. They might not lead you to a diagnosis yet, but you might just say, this is not a normal ECG because of just one person, kindly. One person. Okay. So as you can see, there's a lead V4. It shows that they're heels. Let me say they're heels because I've not shown you the normal. The heels, to me, they are more elevated. As if there was a baseline that I could show you with the normal one, and I'm sorry for that, it will show that these ones are elevated. If you go to V2, V3, they show that there is a deviation from the normal. You'll be able to appreciate that there's ischemia, there's injury, and there's infarction. Both are different and they can be detected with an ECG. Next slide, please. Thank you. So when the myocardial injury persists, MI is the results. This is where we try not to have it persist. During the earliest stage of MI, known as the hyperacute phase, the T waves become taller and narrow. This configuration is referred to as hyperacute or the peak T waves. Within a few hours, these T waves invert, they go down, they go against the axis, the normal axis of the graph. Next, the ST segment elevates, a pattern that usually lasts for several hours to several days. Hence, if a patient even comes and tells you 2 weeks ago, I had an indigestion, you can still pick. But the course of management at that point is different from when the patient would have come with an acute phase. In addition, the ST segment elevation in the leads of the ECG facing the injured heart, the leads facing away of the injured heart may show an ST elevation depression. This finding is known as reciprocal ST segment changes. Now, don't get discouraged when it comes to ECG. We are still learning. Even our consultants take time because there are quite a number of calculations we usually do. But it's good to know what is normal in an ECG on just a glance. This is a normal ECG. This is an abnormal ECG. By that time, once you recognize there is abnormality, then you're able now to sit down and do the demarcation. Is it the anterior wall, the posterior wall, the lateral, the septal? If any of them is affected, what do I need to find? What will be the symptoms? What do I need to do? So yes, with ECG, it's training, exposure. This one is never, we will never know at a glance. One day you'll sit down and just be a guru with an ECG. It just takes time and dedication. Next slide, please. Thank you. So the last stage in the ECG evolution of the MI is the development of a Q wave. The initial downward deflection of the QRS complex. A Q wave represents the flow of the electrical forces towards the spectrum. Small, narrow Q waves may be seen in a normal ECG in the lead 1, 2, 3, AVR, AVL, lead V5, and V6. Q waves compatible with an MI are usually 0.4 seconds. As I said before, ECG is an electrical representation of the heart, and they're usually calculated in seconds in small boxes. That's how we usually do a calculation. And this is represented in more or the width of the fourth or a third of the height of the R wave. Hence, don't be discouraged. I still encourage. ECG can be easy to know when you are calm and relaxed and you're able to appreciate a normal one from an abnormal one. The Q waves is indicative of an infarction, usually developed within several hours of the onset of the infarction. But in some patients, they may not appear until 24 hours to 48 hours after the infarction. Next slide. Thank you. So within a few days after the MI, the ST segment returns to baseline. Persistent elevation of the ST segment may indicate the presence of a ventricular aneurysm. The T wave may remain inverted for several weeks, indicating areas of ischemia near the infarcted region. Eventually, the T wave should return to their upright configuration. The Q waves does not appear, and therefore always provides ECG evidence of a previous MI. So, as I was saying before, if a patient had an MI 2 weeks ago, 3 weeks ago, comes and I do an ECG, and I find a Q wave, it will still indicate that this patient had a history of an MI. Either it was treated or it was not treated. That will it necessitate me to do more tests? Yes. I won't mind doing an angio on this patient to see how far the damage has occurred. Now, depending on the location of the infarct, some of them may run as an emergency to our unit, especially when the patient has a full infarct, especially supplying the left side, hence the pumping site. Patient will come cold and clammy, even if the MI was a long term, like a week or two, and this will be an emergency enough for you to go and see if you can salvage. Most of the time it's hard to salvage because then you'll see how far the damage is. Most patients will either run to theater for an open heart surgery and grafting. Some will have to manage them depending on how the critical presentation. Either we do an angio or we give drugs. Next slide. Next slide, please. Thank you. Q wave indicate tissue necrosis and are permanent. This shows that we have Q waves. This is a Q wave. If you can see my cursor, this is a Q wave. This is an ST elevation. So there usually is a P, QRS, and then ST. So when the Q, there's a P, this is a Q, this is a QRS, and this is an ST depression. As you can see, this is our axis. If I may use my cursor, this is our axis. Now, if you are told usually the Q wave is usually a third of the QRS. As you can see, the QRS is longer, and it's the Q wave that is supposed to start from here has gone way down, and it's a third of the length of the QRS. Then the ST is supposed to be up, but our ST has gone down. It's a depression. Next slide, please. So to attain an accurate view of the right ventricle, the right-sided chest leads are recorded by placing the 6 chest leads on the right side of the heart, using landmarks to those on the left. Most of our standard procedure, as we are taught in school, usually have our ECG done on the left side, as it is assumed that the left ventricle lies more on the left side, and most of our patient comes with more of the left side being an issue. But there are those unique cases that come with a right-sided chest pain. So with all this not presenting on the left side, we usually do a right-sided chest pain, the chest lead, sorry. So the same demarcations you usually put on the second intercostal space, the first lead will be on your left intercostal, second intercostal space, right mid at the junction of the chest sternum. Then the second lead will be opposite on the same side. Then the third intercostal space all the way to the lower part. So it will show us the representation of the right-sided chest pains. This will show how the side of the chest has been damaged, and it will help us to landmark it and be able to sort it out. To detect the posterior wall abnormality, the 3 precordial electrodes are usually placed posterior over to the heart, a view known as V7, V8, V6. We usually have, it's a 12-lead ECG. So when you come to the leads on the chest, it's usually from V1 to V6. The 4 leads are usually placed on the upper arms and the lower arms. Now, if you are suspecting a posterior MI, you have to add 3 more leads. From V6, you go all the way to the spine, straight to the spine, where V6 has been put near the middle of the armpit. Usually continue with the 3, V7, V8, and the V9 usually nears the spinal cord. The V7 is positioned as the posterior axillary line, V6 posterior scapular line, and V9 left border of the spine. Next slide, please. Laboratory tests. We usually pick blood so that we can correlate with the ECG that you've done. Most of our patients who come in, the first thing, if a patient has a chest pain, we usually calculate time. Though to ECG should be less than 10 minutes. So if a patient comes, you do not run fast for blood, or you connect the patient on monitor, do an ECG. The first 10 minutes, I should have an ECG. Then we continue taking the blood to correlate with what we found. As we said, CKMB appears in the serum 6 to 12 hours, peaks between 12 to 28 hours, and returns to normal levels in about 72 to 96 hours. CKMB is an indicative of a muscle burning, a muscle being insulted. Now, we have to differentiate the two. Why? The heart having a muscle, the entire body also has a muscle. So if you are running and you started having, let's say, pains, or you injured yourself, and I do a CKMB, it will also be deranged. It doesn't mean that you're a MI, hence the history. If you come with a chest pain, I do a CKMB, it's an indicator of a muscle being injured. Now I have to really narrow it down. Is it that you are running, you injured your muscle, or is it the heart muscle that has been injured? Or you can also have an accident. People who come in, who have had accidents, when you do a CKMB, it's usually also high because the muscle was injured. The second one, myoglobin. The myoglobin levels can elevate within 1 to 2 hours of an acute MI and peaks within 3 and 15 hours. All muscles have myoglobin. Hence, we need to know, is it a myoglobin because a patient came with a fracture, or is it an indicative on an MI? Troponin T and troponin I. These are produced in the heart, and they are quite crucial in us diagnosing an MI. So when the troponin levels are high, they rise within 3 hours, peaks at 14 and 18, and remain elevated for 5 to 7 days. These are very important in our protocol, in us nursing the patient with MI. The T levels will rise in 3 to 5 hours and remain elevated 10 and 14 days. So which is important? Troponin I. For me, troponin I is important at this point in time. When I take, I'll know the baseline, how high, if it's peak at 14 to 18 hours and remains longer to 5 and 7 days. It's important for me to know now, where do I go? What do I do in relation to the ECG that I've gotten? The second, the next slide, please. This is a graph indicating of the tests that you usually use to diagnose an acute MI. The cardiac markers are elevated, and it shows that the level goes down. The 1 to 10, those are hours. 5 to 50, those are the peak times. The normal ranges is between here. As you can see, the purple one is the normal range, and 0 to 10, these are hours, if I'm not wrong. I'm unable to see way down. Yeah, the days, the lower one, I'm sorry, my slide is way wide. The lower one is days after onset of MI. So from 0 to 10, these are days from onset of MI. Then from 0, 5, 10, 15, and 50, these are the multiple upper reference limits that we have. Next slide. So let's go to management. Patient has come, as we said, though the patient has come. When you say though is the first thing I've seen you, the time I take to see you, to put you in bed and connect you to an ECG should be less than 10 minutes. The ECG will be examined. If there's a presence of segment of a ST elevation, then we have to do an administration of drugs, and usually calculated with time. So aspirin 300, it is chewed, not swallowed, chewed. As we know, the aspirin that we usually give to a patient is usually quoted, and it's supposed to work within a specific time. When it is quoted, it takes longer for the digestive enzyme to digest it, for it to have an effect on the already insulted side. Now, when it comes to chewing, you have already removed the coating. You have reduced the time for it to come and help us in preventing of antiplatelets. It's an antiplatelet. It helps us in preventing aggregation of the platelets at the site of the injury, hence preventing further blockage and further disruption of the blood supply to the area. After recording the initial 12-lead ECG, place the patient on a cardiac monitor and obtain serial ECG. There are ECG changes. If you remember, there are quite a number of ECG changes you will see. There's elevation, there's depression. ECG is usually very important in this patient continuous monitoring. This will show the progression of the insult. Oxygen is needed via mask or via cannula. Most of the time we start via cannula because at that time we have a patient who is able to breathe, able to communicate, so the patient has not worsened. This oxygen is important because it boosts the oxygen supply to that area that has already lost its blood supply. We usually assume at that time we have been warned that there is something going on this side. So at this point, we give you oxygen so that we try and prevent necrosis of the already ischemic area. Continue with the slide. If there is more chest pain, we usually administer sublingual nitroglycerin. But caution, you have to be very cautious when it comes to your blood pressure. What is NTG? Sorry, I'm using that. It's called nitroglycerin, NTG. It's a vasodilator. Very good vasodilator, but it has its own issues. If a patient has a lower BP or a lower heart rate, and you give an NTG, you have opened the vessel wide, there's pooling of the blood, and there's less supply to that area also. So you do not want to go and tip the patient more to the MI side. So what we usually check is if the BP is less than 90, the systolic, we usually try not to give the NTG at that time. There's also an anesthesia called, we usually give morphine. Yes, there's a standard depending. Personally, I usually give 1 ml while observing the patient. It's we usually say give 5 milligrams. I prefer starting with 1 milligram, depending on the patient. Not all patients will respond to the standard stipulated regulations on treating an MI. So yes, you're not treating the disease, you're treating the patient. So you have to really be observant of your patient. Next slide. Thank you. Now, this is now my area, because most of the things that you've, the first aid that is usually done in casualty. So by the time you come to my department, that is the cardiac department in Kenyatta, we are more in the interventional area. So what do we do here? You come with your ECG, your blood works, an echo will be done, but an echo is usually like a more of a confirmatory test, but an ECG is usually the primary that we work on. Then we usually do an angiogram. An angiogram is whereby we visualize the heart vessels, coronary vessels, to see where the blockage is. Now, this is a diagnosis to show where exactly has the insult occurred. Once you're able to determine where and the extent of the insult, then you are able to do the primary coronary interventional. This is PCI, angioplasty, and stenting. Now, when a patient comes and there's a blockage, we usually try to see, can we go through that blockage, open it up the vessel, see how the flows are using a dye. Then once we are able to see that we can able to salvage this vessel, we usually put a stent. A stent is a wire mesh, we usually put to maintain the lumen open. Now, at this point, when you do an angiogram, we are also able to know how bad are the vessels or how many vessels are damaged for us to quantify, either doing a stenting or referring this patient to a cardiothoracic for CABG, that is coronary angiogram bypass graft. Now, in PCI, this is the most effective alternative to reestablish blood flow to ischemic myocardium. The primary PCI is an invasive procedure in which the infarct-related coronary artery is dilated during the acute phase of the MI without prior administration of the thrombolytic. Now, they have mentioned a thrombolytic. There are usually quite a number of, apart from the angiogram, different types of revascularization of the vessels. We usually have the chemical and the mechanical one that we use. Chemical usually use the thrombolytic agent. Some setup during an acute MI, before you go to the cath lab, some will give you the thrombolytic agent. It has its own criteria for a patient to be qualified for it. As you may know, this one usually thins the blood, and there are quite a number of patients who might not qualify for a thrombolytic agent. Now, for the primary PCI, it may be an excellent reperfusion alternative for patient presenting within 2 hours of symptom onset. As I was saying, time is muscle. So if you are meeting this patient for the first time, usually count that time as the initial contact. So DO to ECG, 10 minutes. DO to reperfusion, usually 90 minutes. As you can see, less than 2 hours of onset of symptoms. Usually try 90 minutes that we are in cath lab and we are sorting you out. By that time, you assume, and it has been proven that it is in an ischemic stage, not necrosed. So you're able to salvage that part of the heart that has been injured. So clopidogrel is usually given as a loading, 300 to 600 milligrams, or Tigasel, let me say Tigasel, 180. It's given prior to PCI. In Kenyatta, we usually use both, or we combine clopidogrel 600 and aspirin 600. You chew. As I insist, it is a chewable moment at that time, not swallowing. When you do the dual antiplatelets, that is with aspirin and clopidogrel, or alternative of the Tigasel, is given afterwards. Afterward for the next 12 months. Next slide. Why do we give it for the next 12 months? We usually believe that once we have gone there, we have seen, we have sorted it out, we usually believe that the insult might continue, or we might have other plaques that are usually situated, then they might be disturbed enough to to move again. So we're giving you an antiplatelet to prevent more aggregation on that injured site, especially where the plaque moved, because the platelet will usually, the healing process of an injured vessel is aggregation of the platelet to that side. So when you give you an antiplatelet, is to prevent more clotting on that side, hence forming another plaque, forming another cascade of an MI happening on that vessel. So the other alternative is thrombolytic therapy. This is we give either heparin, we give and tenecteplase. Those are options that we usually give. And this helps in the converting of plasminogen to plasmin. Now, you have to go back to your clotting cascade. Each works differently. Why would I give antiplatelets? The same patient I'll give thrombolytic. So depending on the chemical, they usually work differently on the clotting mechanism cascade. So the thrombolytic therapy provides the maximum benefit if given within 3 hours. Note, it is very time. As we said, muscle is time after the onset of the symptoms. The significant benefit still occurs if the therapy is given up to 12 hours after onset of symptoms. But the effect that you're going to get the first 3 hours after onset of giving the therapy and the effect you're going to get at 12 hours are totally different. Kindly note that. You'll get different reactions and you may get different ECG changes given the time of these two patients coming at these different times. What is contraindicated, as I was saying, to this thrombolytic therapy? If you had a hemorrhagic stroke, you're not qualified. The doses of the thrombolytic is quite high, and it might form you having another stroke. Then I'm going to have problems because now I'm treating the stroke. I want to salvage the heart, and the neuro is telling me, no, you've caused another stroke. So this patient is usually not qualified. If you had any intracranial neoplasm, if you have an active bleeding, either GI, we exclude menses. If you have a GI bleeding, we do not give you. If you have a suspected aortic dissection, we do not give you. This, we might find it during when you're doing an echo on the patient. Next slide. We are continuing with the caution. Severe uncontrollable hypertension or on presentation, that is high BP, you're contraindicated. History of prior CVA on this patient. History is important. It might not cover the contraindication, but it should be a caution when you're giving it. Because as we say, how long was the CVA? It will help us know how and when, what to monitor during that time when you're giving that drug. If you're already on anticoagulant in a therapy dose, if you have recent trauma, head trauma, or we have resuscitated you for that long, or a major surgery, then you are contraindicated in thrombolytic therapy. Next slide, please. It still continues. So we have the streptokinase. We have we've done heparin, I've done thrombolytics and tenecteplase. Those are the different brands that we usually have. If you're pregnant, you're not qualified. So yes, next slide, please. Intensive and intermediate care management. So for prophylactic dysrhythmia, during the first 24 hours of hospitalization are not recommended. IV NTG will continue for 24 to 48 hours. We'll continue giving you aspirin because we are trying to prevent more aggregation of the platelets on the injured area, and the clopidogrel will continue. We can give you beta blocker therapy should be administered within the initial hours of the infarct, followed by an oral therapy, provided there are no contraindications. Reduce the oxygen by decrease. They reduce oxygen. Sorry. They reduce the oxygen demand by decreasing the heart rate and contractility. In this aspect, we are trying to reduce the work of the heart. You've injured the heart. The heart is trying to say, okay, I've been injured, I need to do an overwork. Then it needs a high demand of oxygen, high demand of nutrients, hence it increases the contractility. This will still worsen the MI because of the demand. What we need is at that point is the coronary needs to be enough to be supplied enough. By you reducing the contractility, the rate, and slow the rate to a point whereby when the heart pumps, it able to fill the coronary enough for it to have the reperfusion by giving the beta blockers, and the oxygen demand will be reduced at that time. Just imagine a heart that is beating so fast. That means there's no systole, there's no diastole. Diastole means there's no opening of the vessel for blood supply that has oxygen and nutrients going in. So this is where now we are reducing the demand of the heart so that we are able to salvage the ischemic area. They also increase the coronary artery refilling by reducing the workload of the heart. Next slide, please. Thank you. The AC inhibitors are administered to patients with anterior wall MI and to patients who have an MI with heart failure in the absence of significant hypotension. As we say, where the MI has happened, where the insult has happened, this might lead to a patient having a heart failure. As we are saying that heart failure only happens on the left ventricular because the left ventricular is the pumping system of the heart. We also give the AC inhibitors will also help prevent ventricular remodeling, that is dilation of the ventricle, and preserve the ejection fraction. Heparin is given to patients undergoing percutaneous or surgical revascularization, and from those receiving thrombolytic therapy with atenectaplase. Low molecular weight heparin should be used for patients with an non-Q wave MI. Next slide. Hemodynamic monitoring. We use a pulmonary artery catheter for hemodynamic monitoring. Is indicated in the patient with an MI who has severe or progressive congestive heart failure or pulmonary edema, cardiogenic shock, progressive hypotension, or suspected mechanical complication. Most of our patients who come with MI usually will feel because of no perfusion. The heart has lost its function to perfuse the other body organs. They usually come either cold and clammy. They might be conscious or not really unconscious, but confused. But you can see that they are cold and clammy. They're not able to perfuse the other body areas that are supposed to be perfused. That is usually in cardiogenic shock. So we usually have a pulmonary artery machine that you usually put through the jugular or the femoral site, whereby it's usually entered and situated at the coronary sign, the aorta. It's a balloon pump, as we've heard of balloon pumps during, if you have attended one of these cardiac intervention conversations, and it usually helps at the aorta, whereby the coronary divert to supply the first outlet at the aorta, usually at the coronary arteries that usually supply the heart. So the other part of the body you might run to renal, to neuro, but the first organ that is usually supplied by the nice oxygenated blood is the heart. When it has now the good oxygen, it's able to pump now to the rest of the body. So when you put a pulmonary wedge catheter on that side, it's usually a balloon. It only inflates during systole. This helps in pushing that nice blood enough to the coronary arteries. Then when it deflates, now the other rest of the blood goes to the rest of the body. Additionally, you can do the radionuclide imaging. We can do the echocardiogram or the stress test. Next. PCI. We usually restore the circulation to the affected heart muscle. The procedure is called PCI, percutaneous coronary intervention, short. We use a catheter. We go through the blood vessel of the artery. We usually use the femoral artery or the radial artery. Once the catheter is inserted in the blood vessel, we thread it through the artery all the way to the coronary area. We usually push a dye. We see where the blockage, we calculate how big the blockage is. We usually put a balloon. We thread through the catheter, the balloon. We try to open up the area. Once we see now we're able to open and we see a flow by use of the dye, we can use a stent. We calculate how long the lesion is, and we can put a stent at that point so that the lumen is usually able to be open by the stent. Now, the patient will come, you will put a stent, and you end up putting maybe more than 2 or 3 stents in one vessel, depending on how long the lesion is. Once you put the first stent, usually do the same thing of putting a dye, flashing a dye to see if it's still patterned, because there are some stents usually collapse depending on the pressure. So we usually try to see, before you leave our table, we are usually either quite certain that we have reperfused the coronaries. Next slide. So PCI is a critical tool in restoring the blood flow, and the sooner that happens, the better the chances of good outcome. Hospital use a metric called door to balloon time, you heard me mentioning, to measure the ability to treat that heart attack. This is the average time it takes for a patient to undergo PCI after they have first come into the emergency room. So PCI often includes the placement of a stent at the site of the blockage. The stent is made of metallic mesh and looks like tube-shaped scaffold. They help hold the artery open so another blockade does not happen in the same spot. Some stents are coated with are coated enough to indicate that they prevent clotting or tissue growth on the stent itself. This can, because at the stent, sometimes you put a stent and you can still get a blockage on that stent. So it usually happens. Hence, the patient is usually put on antiplatelet, if you remember the other slide, for 12 months to prevent aggregation of platelets to either that site of the foreign body or to prevent another blockage that might happen on the injured site. Next slide. Now, you have come to me in cath lab. We have done with our cardiologist interventional, we've done our stenting, we've done our PCI, we've done first our angiogram process, we've done our angiogram, we've seen where the damage is, we've done our PCI, it was either successful. Now comes this patient that we've done an angiogram, has multiple lesions that we are unable to stent. This is where you'll see some intervention mention. Now you're going to put a metal jacket. Metal jackets means it's a whole long lesion. If you remember the arteries that I was showing you, and you're going to be putting stents after stents after stent, it is usually not safe for the patient. So the coronary artery bypass grafting, this is whereby now we just need to do put new vessels on you. So this has several blockage. The coronary artery may undergo coronary artery bypass grafting. This is where now we call the cardiothoracic surgeons in Kenyatta. This surgery is often called open heart surgery. We open the chest, visualize the heart, stop the heart, visualize the heart nicely, see with the help of the angiogram that was done by the interventional, we know which coronaries have been damaged. Then we are able to harvest the vessels, especially on the legs and the lemur, on the mammary area, so that we do a bypass, meaning where the blockage started and where it ended. We put an artery connecting where it started, we bypass where the blockage is and connect where the blockage has ended. When you're doing an angio, we usually visualize the right and the left. As I was saying, they always meet down at the left ventricle so that we see how the collaterals have worked. Most MIs usually happen and they will form collaterals. And that is where we usually say we prefer an MI that has collateral than the one that doesn't have, because now it means the damage is even more. So when you're doing a cabbage on this patient, we usually move, either take the vein, we connect from where the start of the obstruction towards the end of the obstruction. Hence, we are able to bypass where the lesion was. Yes, next slide. So complications of these procedures. We can have recurrent ischemia. We can end up having recurrent infarction. This was on the vascular complications. On the mechanical complications, we can have left ventricular free wall rupture during that procedure. It is still a procedure that you have to get consent, explain to the patient what can happen during that procedure. You can have ventricular septal rupture. You can have the papillary muscle rupture. We can end up having with acute mitral regurgitation. On the myocardial complication, systole and diastole dysfunction, congestive heart failure, hypotension, cardiogenic shock, right ventricular infarction, ventricular activity dilatation, you can have aneurysm. All procedures have risks, and these risks have to be explained to the patient. When you come to Kenyatta, we sit down and explain to you the urgency and the consequences of these procedures, so that this patient is well informed and able to cooperate and able also to follow up with the instruction post the procedures. Next slide, please. Pericardial complication. You can have pericarditis, you can have effusion. When it comes to the thromboembolic complications, you can have mural thrombosis, systemic thrombosis, DVT. When it comes to electrical, you can have ventricular tachycardia, ventricular fibrillation. All this can happen. And it has happened, especially on the electrical part. It usually happens on the table during an angiogram or PCI. Yes, they usually happen. We even have to resuscitate, give drugs. So these are complications we need to tell the patient. If these complications happened, what are the consequences? What will be the effect of the heart? Because the patient might come with the notion that I'm being sorted out, so I'm going to return back to normal. But if you end up having all this cascade of one incident after the other, the patient needs to be aware that there will be some limitations to the lifestyle that he or she has. Next slide, please. Next slide. Thank you. So risk factors, age and sex. Your risk for heart attack increases as you get older. And your sex also influences when your risk of heart attack starts to increase. Men, the risk of heart attack increases greater than 45. Women, as greater than 50 or after menopause. As we say, our hormones usually, in women, our hormones usually do a major role in controlling quite a number of our systems. We also say with age, the muscle gets tired, the heart has been working all through. So now at 45, at 50, it is like, okay, I'm done. My engine is usually taking some time to be faster than the way we are young. So yes, you might get this risk at this time. So kindly, our age, 45, 50, once in a while, get an echo done. Regardless of you having signs or not, just get a simple echo done. It will take you less than 3 minutes. Just getting an occasional echo. Let's say every 6 months, depending on your lifestyle, or once a year, or during your once a year physical exam that you usually get. Next slide, please. Just a few minutes to finish. Okay, family history. I've seen some questions. We can start our Q&A, but let me just finish because there's some few slides going on. Family history also matters. If you have a history of an MI in your family, it should be a concern to you so that you'll be able to take care of yourself, because you can be a potential person at that time to get an MI. Next slide. Lifestyle also, smoking, chewing tobacco, too much alcohol, sedentary life, lack of physical activity, high sodium, high sugar, fats. Those are also part of risk factors that may lead to MI. Next slide. Diabetes, obesity, high blood pressure, high cholesterol, eating disorders can also be a health condition that may lead to being a candidate or visiting me in my cath lab. I think I'm done with the presentation, unless there are some more slides. I think I am done. Thank you all for listening and giving me this moment. So I'll lead to the moderator to take over and yes, give us our way forward. Thank you. Amina, questions? Okay, I've seen on the QA, what is the time frame needed to make a decision for PCI? Door to needle is usually 90 minutes for the PCI. Door to needle, 90 minutes PCI. That is from Saitoti George. Sirma Chebet, cause of sudden sharp pain. Cause of sudden sharp pain. I think that was it was a comment. Afwande, if a patient reports of episode of arrhythmia, ectopic heartbeats, especially some days after a shock of having had bad news or just bangs, despite having a normal or controlled BP reading. As I was saying before, usually we can do a standard ECG on arrhythmias. Emotions are one of the things also, especially with women. When you are emotionally, some of us get chest pains, get palpitations. I won't mind us doing an ECG on this patient and checking further. But if it only comes during an emotional moment, it means you've stressed the heart. Hence, you have the heart needs as an occasional angina. It's an angina which usually released by itself or by just taking a rest. Let's say you are running and you get a chest pain, just take a rest. If you take in nice breaths, relax, put your feet up and it goes away, then that's an angina. Though it's an indication that you need to take care, you need further tests and taking care of yourself. Thrombosis in public hospital, is it possible in view of the cost?
Sorry. Hello. Hi. Can you hear me now?
Hello. Hi. Yes, I can.
Yeah, sorry. I don't know what happened in Mekata kwa laptop. I had to go through the computer. But thank you very much for the very educative session. It was to the point. It discussed very different stages of an MI from the ED to even the cath lab. And there are many questions that came up. Just to add, because I was in the ED for a long time, one of the few
Yes.
things that probably I can add to the discussion is oxygen therapy. The new guidelines are recommending that we do not supplement if it's more than 90. Unless it's
Yes.
less than 90, we
Yes.
supplement. And another thing in my practice was right ventricular infarcts when
Yes.
with nitroglycerin. So
Yes.
that's very key.
Mm.
Together with, of course, a history of Viagra, if people have been using Viagra. Now,
Yes.
it's bringing me to a question. I'm sorry for my chain of thoughts, but menopause. You mentioned something about menopause because you said sex is a factor for women. I've seen women
Yes.
as young as 30 get menopause. Have you ever? What's the youngest age you've ever seen somebody with an MI? Because personally, I've seen 30 with a
Yeah.
stroke, but yeah, over to you.
For an MI, now I won't say about the menopause, but the youngest I've treated was a 28-year-old, but she was more of a postnatal. She was, I think, 7 days old postnatal, and she ended up having an MI. That was the youngest I've treated. For menopause, it's variable because I've not encountered 30-year-old with a menopause or suggestive of and has an MI, but mostly they have other issues. Postnatal, that one I've treated. Like the history I was telling you of probably the young man, that is a history. As we've noted, most of Caucasian people tend to have more of the MI that I've encountered compared to these other colored people. So yes, there are quite a number.
My goodness, that's interesting. As young as 6 days. I had that
Yes,
correctly,
7 days
right?
postnatal. No,
7 days.
7 days postnatal mother.
Oh, postnatal mother. Okay, fine. Sorry,
Postnatal
I was
mother, and that was
misunderstanding.
a 28-year-old lady.
Wow, wow. So
Yes,
okay, that's heavy.
yes,
And then now David Munjuri is asking about public hospitals. Maybe you can elaborate more. I am familiar with the cath lab in Mombasa and Kenyatta
yeah,
in the public hospitals.
yes.
What more can you add? Like which hospitals do you know that give thrombolytics, even in the ED department? Because I know we do that here in Kenyatta to
Yes.
several patients. So maybe you can elaborate more on that.
Okay, so Kenyatta, with it, mostly the Tenecta place is quite expensive. So we usually have to first have a contract with this patient that is able to purchase this drug. Same with the public hospital, because it goes for, in the private, it goes for like 500,000 of the drug. And this drug does not mean that you won't land in cath lab, because that's another cost. So you have to be very careful when you're talking to this patient about the cost of the thrombolysis, what it does, and it does not prevent you from landing or having other complications, so that they may understand the cost implication of this entire process. I have not given, I work in a cath lab, so I've not given a thrombolysis in cath lab. Most of the time, it's a first line to be given at casualty before I receive you in the cath lab. Have I given a thrombolysis in my previous?
Thank you. And again, I'm sorry. From my experience, I can speak just on behalf of Kenyatta because that's the only public hospital I've worked at.
Yes.
Yes, we do give thrombolytics in the ED. Of course, it's based on availability.
Yes.
The price, the last time I checked, it was about 50,000 to 60,000.
Yes.
However, priority of life comes first in the ED. So if it's available, they will by naturally will have to give you whether there's money or not. But if it's not available now, probably you'd have to buy it outside.
Yes.
For the other questions, sorry,
Yeah.
Zoom yangu, Um, there was somebody asking, I think somebody anonymous, but I think it's crucial. What's the difference between MI, angina, and heart attack? I know they mean the same thing, but maybe from your perspective, you can elaborate it more and demystify those terms.
Okay. Oh, before I forget, there's someone who asked if the course is held by NHIF. No, NHIF does not stand for thrombolysis. In Kenyatta, NHIF stands for, it'll cover you on the, when you're coming to the cath lab, there's some procedures it will cover you fully, and other procedures you'll have to pay a quarter of the total amount. So yes, NHIF, so far we'll encourage everyone to have an NHIF. Regardless, it helps. So far, I've seen people being sorted out in our cath lab, and NHIF has really helped us a lot. Now, when it comes to MI angina, MI chest pain. Chest pain is a pain. It's a layman saying, I have pain in my chest. Angina is it's the medical term that I have angina. It still means I have a chest pain. When it comes to MI, myocardial infarction, it is now this is a diagnosis that I've done. You have come, explain to me, I have a chest pain. That is on the layman's. On my part, I've said, okay, that's an angina. Now I need to know, is the angina progressing to a myocardial infarction whereby the myocardium has been deprived of the oxygen and nutrients that it is dying? So that is how we usually the terms are. I hope I've explained well.
Yes, quite so. There's also a lot of discussions from various people on
Yeah.
the dosage of aspirin.
Yes.
What are your take on dosing of aspirin? How much should you give? If they're asking in terms of long term, they're also asking in terms of, I'm already vomiting, I have a history of PUD. Is it like a complete contraindication of giving aspirin in MI? Basically, in a nutshell, maybe you can summarize that.
Okay. Thank you for the question. It is a dilemma we usually have, but on our part, for the dosage, when the patient comes to the ED or first contact with the patient, chewable, I usually give 600. Usually it's give 600 chewable, 600. Long term, it will be determined by, I've not seen higher than 75 OD. I've not seen higher than that. Post doing the reperfusion, we usually continue with 75 once a day. Rarely we go to a BD dose. For if you have contraindications, at that point in time, the heart is more important than the GI. We'll still give you the aspirin to chew. Yes. Unless
Yeah, thank
otherwise.
you. Sorry, thank you. Maybe just to add, dosage of 75 is not known to cause gastritis. It's not sufficient enough to cause gastritis. So it's not an indication, contraindication for taking it long term. And so give people aspirin. It's like Kisato correctly said, it is more important. The heart is more important than having a GI. Kisato, there's a question on transplant. Somebody was asking, what happens if even CABG fails? Like if you have a CABG and it fails, what's next? What are the talks you've had about heart transplant? I know it's a very tough question to tackle, but go ahead, give us an answer.
Okay, so I've done all this intervention. You're not qualified for open heart surgery. Even if you do the bypass, there are people who I've treated, they went to India, they came back with an MI on the same area. Now they have really gone to worse, that is total heart failure. They're actually dependent on all these gadgets that we usually put, like the pacemaker, the higher end pacemakers that we put, and needs a transplant. let's start with first our culture. African culture does not allow you to remove organs and put someone else apart from the kidney. And that is also a whole process of explaining and them to understand. Now imagine you're removing a heart. We don't even have a donor protocol in our setup, apart from the kidney one only. We don't have a donor protocol when it comes to patients who are qualified to donate organs. For a patient to qualify to donate the heart, the patient has to have brain dead. I mean, this patient is brain dead, and you need an expertise. We need all this mechanism to be put in for you to have this heart to be transplanted. Now, seeing our culture does not allow such, we have already removed transplant. Secondly, we are currently not equipped technical-wise, machinery-wise, human resource-wise to do such transplant. So in KNH, you'll either be referred outside the country for the transplant. Now, during that time, you either sort yourself out financially to go to the countries. I cannot say about India. I will not say much about India because I don't know if they do transplant yet. Though they do all these other procedures very well. America, yes, they do. The European country, they do because they have really established that area, and they have donor protocols that have been passed, and they are accepted by the society. So, I mean, would you want at one point in time a relative of yours in the ICU is brain dead, has very good organs? Let me not go far. We are already a donor unit. Our country is a donor. If you were to supply organs, we'll be the richest country ever.
I know.
Simple as
it's sad, but I know. I've seen enough. But what I can say is you're correct in stating the differences in culture. But more importantly, we do not have established laws on transplants, and we should probably start advocating for this. In the country, we're only doing live to live donation. There's no dead to live donation for any organ. The only transplants so far that I'm aware of in the country is kidney and corneal, if I'm not wrong. At the moment in Kenyatta, we only do corneal, but we're building capacity for corneal and liver transplants. We're hoping we're going to start that very soon. And also, if any of you are looking for services of HLA typing, Kenyatta has a lab to do solid organ tissue typing to see if you're compatible as donors. And it's the only lab actually in East Africa. I can see time is up. Sorry, I can't address all the questions. I can't ask Kisato all the questions, but maybe Kisato, you can give us a parting shot from your experience and what you would want the audience to know in maybe 2 minutes before we end the session. Thank you.
Okay. Parting shots. Thank you very much for this opportunity for me to present MI. Number 2, take care of ourselves regardless of our backgrounds. Walk to our, we charge, it's 3,500 if you're a Kenyatta person with an IP of Kenyatta. We do an echo and an ECG. Standard ECG is 500. Have it done. You don't need to print it, just have it once in a while, get it checked. Let's learn to have a more active life. I know with this middle setup where we do pizza, we do stuff, let's also take care of ourselves and our coronaries. Yes, I might need you guys to come here. This is my job. I don't want to be absolute. But at the end of the day, I want to see someone walking out, even if I do a good job, and you walk out knowing that I am okay, I'm sorted out. For Kenyatta, you're welcome to Kenyatta. Kenyatta has a fully functional cath lab. We do angios, we do PCIs, stenting. We do coronary intervention and diagnosis in the cath lab. We do pacemakers. It is NHIF covered. NHIF covered. As I was saying, there's some, yes, procedures you might pay a quarter of the total amount. But if you have an NHIF, I guarantee you, even if you are told that quarter is like 250,000, there's a whole of 700 that we sorted out. Our angios go for 70,000 shillings only. Ukisimamia na NHIF. When it comes to our PCA is 500. It is covered by NHIF. If you go to a private hospital, it is more expensive because they charge you per item. When you land in our department, no matter how many stents I put on you, no matter how many catheters I open, I will only be limited to that 500. So I will not charge you as per item, I only charge you as per the package. As far as I'm concerned, we have very good interventional cardiologists in the department, very good cardiac nurses, and they are able to cater for your needs within the stipulated regulations of Kenyatta National Hospital. Thank you.
Thank you very much, Kisato, for that very educative, informative, and eye-opening discussion. The only centers that I am familiar with that have cath lab are Coast General and Kenyatta National Hospital. I stand corrected and stand guided by the audience
for
and
the
anybody
public,
with more information for the public. And public hospitals are striving to achieve excellence so that the financial burden for patients and their costing becomes more efficient and more effective. It's for us to know and identify all of these things. There's somebody from Turkana who said, thank you very much for the session. Please, somebody from Turkana or Nani, the only thing you'd need to do is recognize these symptoms very early and refer them appropriately to the correct facility as fast as possible. We'll strengthen our referral systems with the assistance of all of us. And thank you very much for listening, for giving your humble compliments and comments. Nelson had shared how to get the webinars in case you want to achieve the webinar. The screen right now is showing the password for the Nursing Council in case you can only access this after 48 hours. For the clinical officers, you'd be getting your, I hope we already have the approval. For pharmacists, sorry, I know we've been having many challenges, but I am confident the challenges will be over soon. So thank you very much, everybody, for listening. Please share your thoughts and considerations with the KNH medical research team. For next month, we're going to have a series on toxicology and poisoning. Stay tuned for that. We'll continue with our nursing series and all the other series. Thank you very much. Have a lovely evening, afternoon, and bye-bye.
Bye.